Hello everybody and welcome to case 2 of our preparation for practice week, our clinical cases. So by the end of the session you should be able to feel comfortable explaining why accurate histories are important in managing an overdose, know where poisoning guidelines and advice can be found, define which individuals are at high risk of hepatotoxicity and prescribe the treatment for a paracetamol overdose. So you will have already met Megan in your primary care sessions. Just as a recap, Megan is 25, who has been brought into our acute medicine unit after vomiting after taking an overdose with 5 glasses of wine. She called her ex-boyfriend after taking the pills, telling him that she felt suicidal. The overdose was at 6 o'clock in the evening and she arrived in the emergency department at 11 p.m. when bloods were taken. She has a background medical history of anorexia nervosa and excess alcohol intake. So your first question, and then pause the video till you have an answer. Which single piece of information is most important to find out at this point? A, when she last ate something. B, the type of pills taken. C, drug allergies. D, previous overdoses, and E, if she is known to any psychiatric services. Well, the answer is B, but actually they are all important and I'll go through each one in turn. So when she last ate something actually is quite important. So if, for example, she had a full stomach, we would be worried about aspiration, and it might be that we want to electively intubate her to protect her airway, or we keep a very, very close eye on her. If she hasn't eaten for some time, it might be that she's ingested alcohol. It might be that she has a low blood glucose, and that will need treating accordingly. So the type of pills taken, of course, is ultimately the key piece of information we need to know so that we can manage an overdose appropriately, and more importantly to know if there's an antidote, which there is in the example of paracetamol overdose. Knowing their drug allergies and any drug history is really important, and this can be for obvious reasons if we want to treat her with something, and also if she's on multiple complex medications, there is a real possibility of interactions with the drug that she is overdosed on. So for example, I'm thinking about patients who have overdosed on their immunosuppressive medications, for example, or their highly active antiretroviral treatment in the case of HIV treatment. Previous overdoses and whether she's known to psychiatric services are important, not necessarily in the clinical management, but they are important in us establishing the level of risk, so and the likelihood of suicidality, and whether she will likely to need sectioning or whether she is at high risk of harm to herself or others. So on further inquiry, it revealed that she had taken a total of 20 paracetamol tablets, which is equivalent to 10 grams. Each paracetamol tablet is sold on package as 500 milligrams. As a single ingestion, and this is quite important to know, no other medications and with alcohol. Now, why is the alcohol important? Well, alcohol delays gastric emptying, and so she has had these pills on a large amount of alcohol. It's quite possible that she will vomit significant amounts, develop hypovolemia, and of course aspirate, which could be very serious. So on our A to E assessment of Megan, her airway is patent, her SATs are 99, on room air she has normal breath sound and respiratory rate of 20. Her pulse is 105 with a blood pressure of 135/72. Her JVP is not seen, heart sounds are normal, her pupils are equally reactive to light, equal in size and reactive to light. She is alert with a temperature of 36.8. Her abdomen is soft and non-tender, and a capillary glucose of 7.4. There's evidence of self-harm and a low body mass index. Now, this is quite important to be mindful of, that very often, particularly in something like paracetamol overdose, when these patients initially present, the clinical examination may be normal, but it's important to avoid and ignore that fact for a moment, because actually if you don't treat something like a paracetamol overdose, she will deteriorate and go into a fulminant liver failure within 12 to 24 hours, which could be fatal. So next question for you: which is the single most important set of bloods that you would request? A. Paracetamol level, UCL's bicarbonate liver function tests, INR and a full blood count. B. Paracetamol level, salicylate level, liver function tests, UCL's and an INR. C. Paracetamol level, liver function tests and magnesium. D. Paracetamol, salicylate, full blood count, UCL's, LFTs and TFTs. And finally, blood cultures, full blood count, calcium and paracetamol level. Pause and replay when you have the answer. So the answer is A. Similarly to other medications, paracetamol is a drug that we can measure and to determine how much of the drug is in the blood level. So other drugs include, for example, digoxin, aminophylline, salicylates, theophylline, sodium valproate, and so on. UCL, so we want to know if there's been any renal injury and whether there's any electrolyte disturbance. Bicarbonate to see if there's any acidosis. Liver function tests, of course, are key to know if there is any pre-existing liver injury or whether liver injury has already occurred in this patient who's taken an overdose. INR to determine the synthetic function of the body. Again, a deranged INR would point to ongoing or increasingly deteriorating hepatic failure and a full blood count. So let's have a quick look at the others. So salicylate levels, we used to historically do salicylate levels in pairs. We used to call them P&S levels, but actually salicylate levels, the occurrence of salicylate poisoning is now relatively rare. So, and this is due to changes in legislation into how much aspirin people will be able to get over the counter. So the occurrence of aspirin overdose is relatively rare now. Magnesium in answer C, well, it may be helpful in someone who we are concerned about has anorexia or has electrolyte deficiencies, but again, it's not going to change our immediate management or give us an idea about how severely affected she is by the paracetamol overdose. In D, you've got thyroid function tests. Again, they may be useful, but they are of no prognostic or clinical value at this time. And in E, it's got calcium and blood cultures. Again, neither of these are relevant. There are no signs of sepsis, therefore doing blood cultures are not going to change her immediate management, and there is no indication to give her IV antibiotics. So what is the treatment? So it depends on the type of overdose, and what's really important to say to you is that when you approach these patients who have potentially taken overdose, sometimes they can be difficult to manage. They may have had previous hospital admissions and therefore be very used to either how they were treated before or the treatment pathway for their overdose, or any of these things. So it's important that you go with an open-minded approach and that you'll be prepared to be listened and prepared to be empathetic. So let's have a look at the different types of overdose. So there may be ones that are taken over at an hour or less, and so timing here is critical, and if you're unsure about the timing, we will come on to what to do in a few slides. So if your patient, for example, has taken overdose at 6 p.m. and presents to the emergency department at 6:30, we would probably give the patient activated charcoal and then perform their blood levels at 4 hours. Sometimes patients describe a staggered overdose. So this, for example, is where the patient develops suicidality or the intention to harm themselves. So they might start drinking, let's say, at 2 o'clock in the afternoon, take their first paracetamol at 4 o'clock, then some more at 6, 8, 10, and so on. That's important because it then becomes impossible to accurately determine the amount of drug that's in their body, as some will be metabolized, and so therefore it's very hard to tell, and these are the type of patients that we treat regardless. Then there's what we call a therapeutic overdose, and we do see these from time to time. So a good example of this is when the change of NHS dental contracts. It can be very difficult these days to access an NHS dentist, so lots of people are out there that have poor teeth and get very nasty toothache, and then start taking paracetamol and codeine to help with their pain. Obviously, for those of you that have had toothache, I can empathise. The pain can become pretty unbearable. You feel want to rip your tooth out, so you start to take more and more paracetamol and codeine, and therefore in the attention of treating your pain rather than trying to self-harm or overdose, you accidentally give yourself a therapeutic or iatrogenic overdose. So, paracetamol overdoses that are taken over 1 hour or less, this is usually in the context of self-harm and suicidality. The fact that the patient has wanted to attend for help almost immediately is usually a good sign. If the levels are 75 milligrams per kilo, it's unlikely that serious toxicity will occur, and so therefore it's important that you get an accurate history and do the accurate mathematics, and also of course take into account the weight of the patient. Again, if you have a patient who is partially intoxicated or unwilling to give you a history, again, we will come on to that shortly. So the management depends on the time between the overdose and presentation to hospital. So the ideal thing that we do is we try and do 4-hour blood levels. And again, I'll show you the nomogram as to why that's important. The key learning point here is if you have any uncertainty, then you should treat them. Mismanaged paracetamol overdose can be fatal. So up here I've put a brief summary of how to manage paracetamol overdose at various times of presentation. Just to say that patients who are presenting 24 hours after overdose, if they have taken a significant overdose, will often be extremely unwell, show signs of hepatic failure, and will potentially need a transplant. And we will treat these patients aggressively with antibiotics, antifungals, and a whole raft of other medications. So let's quickly look at Megan's blood. So this was 5 hours after ingestion. There are a couple of things to point out. So her INR is 1.2, which is above normal. She has an ALT of 45 and an AST of 40. Now, there are two red flags here. One is that she already has pre-existing liver disease, or she has a mild degree of alcoholic hepatitis if she is a significant drinker, or that she is already starting to see the toxic effects of the paracetamol. Now, you'll notice that both her ALT and AST are both only just above normal. It's really important to disregard that. You should take them as abnormal and as a red flag, and I'll explain why that's important in a moment. Her paracetamol levels are 115. So ignore this diagram. This is an old treatment line that you may have seen early on in your clinical training. This has now been disregarded, and we don't use this anymore. And this is the new treatment line here. So if we look at her bloods, there's the X here, which is above the treatment line. You can see where the dashed line, I have expanded the treatment line, so you can see that her at 5 hours, her blood tests are well above the treatment line, therefore she must be treated. Which single treatment would you prescribe, if any? So A, activated oral charcoal, B, N-acetylcysteine, or otherwise known as Parvolex, C, naloxone, D, no treatment, and E, IV fluid. And the answer is N-acetylcysteine or Parvolex. So what's important here is the recognition about that your patient requires treatment. It's really important to have a very low threshold for commencing treatment with Parvolex. So I was an ICU registrar a number of years ago, and we had a patient who was a relatively fit, well young man, I think he was about 28, had had an argument with his girlfriend, and had borderline LFTs, which is why I was coming back to paying attention to levels that are slightly above normal. This chap was normally fit and well, but was abusing anabolic steroids, which had then caused fatty liver. So he had borderline LFTs. Unfortunately, his paracetamol level was also borderline, as were his LFTs, and he was discharged. Within the 12 hours of discharge, he represented in the middle of the night with severe abdominal pain, early signs of encephalopathy, vomiting, deranged LFTs, and went into full-blown liver failure. And then I had to take him for a transplant at less than 12 hours later, which gives you a rough idea about how important it is to recognize paracetamol overdose, B, take it seriously, C, take a good history, D, make sure you're absolutely sure that you don't need to treat the patient, and also to treat it aggressively when you do, and always be careful about borderline results, especially when dealing with hepatotoxicity. Naloxone is a treatment for opioids, therefore there has no role in this. D, of course, as you can already see, he has deranged liver function tests, and his paracetamol level is above the treatment nomogram, therefore D should be completely disregarded. E, he may need fluids, but at the moment giving IV fluids is not the most important thing. It'll be given supplementary to the N-acetylcysteine. So here's a diagram here of paracetamol metabolism, just to remind you of your biochemistry days. This here is a treatment nomogram. I've put the reference for the Emergency Medicine Journal up at the top for you. As you can see, basically there are 3 bags of N-acetylcysteine that are given. Let's say, for example, Megan Jenkins is 50 kilos. So she'll have 200 mils of 5% glucose, which will be administered over 15 minutes. It's 150 milligrams per kilo. Assuming Megan is 50 kilos, it'll be 7,500 milligrams, or 38 mils of an ampoule. And as you can see, you can work your way across for Megan's weight at 50 kilos to say that her second bag would be 2,500 milligrams of N-acetylcysteine, and the third bag will be 5,000 milligrams of N-acetylcysteine, this time over 16 hours. At the end of this treatment, we then repeat all of Megan's blood tests. So there are some patients that we would be concerned about enhanced hepatotoxic risk. So P450 induction, so certain drugs such as rifampicin, phenobarbital, phenytoin and carbamazepine. Although, to be fair, we prescribe these drugs relatively rarely in the general population. Alcohol, and you can have patients who have a glutathione depleted liver, so genetic variations. HIV, although I'd argue this is much less of an enhanced risk. Malnutrition, and those who have alcohol related or pre-existing liver disease. Just for your information, on Moodle I have created a tutorial about drug-induced liver injury, and it's under the acute medicine section on Moodle. So to recap, treatment of paracetamol overdose depends on the type of overdose and when the patient presents to hospital. Overdose taken over 1 hour, staggered or therapeutic. So staggered overdoses are excessive amounts of paracetamol which are ingested over longer than 1 hour. Serious toxicity may occur if over 150 milligrams per kilo of paracetamol in any 24-hour period. In some patients, toxicity can occur with ingestion between 75 and 150 milligrams per kilo of paracetamol, and doses less than 75 milligrams per kilo of paracetamol are unlikely to be toxic. However, this is more really for academic interest. I would always say that until you are certain about the how much paracetamol has been taken and when, we should treat them. So here's the treatment bottom line. NAC should be commenced without delay in all patients who have ingested a staggered overdose or there is uncertainty about accuracy of given information. It's also important to realise about the type of patient we are looking after. Those who have suicidality and intention to kill themselves despite presenting to hospital may well misstate their dose and or the timings, and so you also have to degree an exercise of caution about when you are examining and discussing the poisoning with your patient. You want to check paracetamol concentration, use NEES, bicarbonate, liver function test, FBC and INR at least 4 hours, but be mindful of course that at a staggered overdose, paracetamol concentration will be useless and should not be used as a decision about whether you will treat or not. This is just a definition of a therapeutic overdose. So this is what I was telling you earlier about patients, for example, who have taken lots of paracetamol for toothache or something similar. Basically where patients can ingest paracetamol at a dose greater than the licensed daily dose and more than equal to 75 milligrams per kilo per 24 hours. Sometimes we do have inadvertent use of more than one paracetamol containing products, so things like sort of these sort of flu remedies and then paracetamol on top. Obviously in the USA they call it acetaminophen rather than paracetamol, so again the drug is the same but the names are different. This is a short summary slide about therapeutic overdose. Patients with clinical features of hepatic injury, such as the one as I was describing to you earlier, such as jaundice or hepatic tenderness, should be treated urgently with N-acetylcysteine. So, question, what makes this patient high risk for hepatotoxicity? So A, suicidal, B, evidence of self-harm, C, anorexia nervosa and ingestion with alcohol, D, female sex and a blood glucose of 7.4. Pause this and then move on when you have the answer. So the answer is C, anorexia nervosa and ingestion with alcohol. I would argue to a degree that all of them potentially we do see higher incidence of drug-induced liver injury in female as opposed to men. Her suicidal intention may mean that she has pre-existing liver injury or evidence of cirrhosis, such as if she's alcoholic, for example, and also it may be that she misstates the overdose. So where can we go for help? So ToxBase is a standard national database that we use here in the UK. Any emergency department that you work in on rotation or acute medicine unit will have access to ToxBase. It's online, or there's a national poisons helpline. Just as an FYI, which I didn't know until recently, if you have an NHS email address, you can access the ToxBase app for free. However, actually, for those of you that might not, because obviously you guys have university email addresses, you can access ToxBase for a small fee. I think it was about £6 on checking. There will be a local toxicology service, which I believe is based at King's College in London. The hospital intranet of any trust that you work on will have a paracetamol overdose management protocol. I've also put a couple of BNF references, one about the prescription of paracetamol and secondly about the treatment summary for poisoning. As well as paracetamol, it also has treatment advice for other overdoses. So when to refer to a liver unit, so for example in London there are liver units at King's College in London and also the Royal Free here. If the patient develops an acidosis, or there is grade 3 or 4 encephalopathy and an INR of 6.5 and renal impairment as defined by a creatinine of greater than 300. Although having an interest in hepatology and working with my colleagues at liver unit here, I would always say if there's anyone you're concerned about, then you should always ring your local hepatology team. Up here, I have put the West Haven criteria for grading of encephalopathy, and this is from the University of Washington. Basically, you have grade 1 encephalopathy, trivial lack of awareness, euphoria, anxiety, shortened attention span, going up to grade 3 and 4 encephalopathy, somnolence, confusion, gross disorientation, and 4 coma. These are the type of patients who will very likely to need liver transplant if they're a candidate, and intubation, ventilation, and management in critical care. So let's go back to Megan. So she was treated for 24 hours. So she had her 3 bags of Parvolex. She had repeat blood tests, INR, liver function test. Using these are all normal at the end, and she's been clinically well. It's important to say that we only do paracetamol levels once. There is no benefit whatsoever in doing repeat paracetamol levels. The consultant then tells you that she is medically fit for discharge. So what does medically fit mean? So medically fit means that they've completed all their treatment that's required from a medical point of view, and that we can, from a medical perspective only, discharge them. So question though, who should best be involved after the patient is medically cleared but before discharge? A, the hepatology team, B, her next of kin, C, psychiatric liaison team, D, community psychiatric liaison nurse, and E, her GP. Again, pause the video now until you have an answer. So the answer is C. Let's go through the others though. So at this stage, there is no benefit of adding hepatology team. There isn't any scope for her to be followed up. She has normal liver function tests at the end. It seems that she has no pre-existing hepatic disease, so therefore there's no benefit of her being seen by the hepatology team. She doesn't need a transplant or follow-up in their clinic. Her next of kin. Now this is really important. Again, this comes down to ethics. So if Megan gives consent for her next of kin to be informed, or Megan deteriorates to such a degree that she no longer has capacity to make any decisions for herself. Let's say she gets a lot worse and gets grade 4 encephalopathy and is confused and in a coma, then in that case we would go to her next of kin. It's very important, even in overdose, to protect your patient's privacy. They have an absolute right to confidentiality, and sometimes we have made grievous communication errors by discussing things with people that we shouldn't have. So again, I'm mindful of let's say Megan has an abusive boyfriend or something like that. The last thing we want to be doing is discussing Megan's medical care with an abusive partner. So where possible, we should always seek patients' consent before discussing their treatment or diagnosis with anybody else. So although she is medically fit, obviously from your beginning slides we'll know that Megan has a background of anorexia nervosa and previous self-harm. We want to know about what support she's getting, whether she needs further psychiatric input, voluntary section, or whether she can get followed up in the community. Therefore, the mental health liaison team is crucial, and nearly all A&E departments will have a mental health liaison team attached to them. So community psychiatric liaison nurse, well, unfortunately she can't access D without accessing C and E, so therefore this answer isn't appropriate. It might well be that she will have a community psychiatric nurse, but this can't be instigated without the liaison team's involvement. So her GP, of course, must be really important. So this Megan, as you will do discharge letters for, must be informed so that the GP can be aware of Megan on their practice radar. But again, we don't need to necessarily discuss with the GP before Megan gets discharged unless there's any specific pieces of information to hand over. So you now should be able to explain why accurate histories are important in managing overdose, know where poisoning guidelines and advice can be found, define which individuals are at high risk of hepatotoxicity, and correctly prescribe medication used in paracetamol overdose. And with regards to the last one, you're going to also have a prescribing workshop, and you can also have a go at prescribing N-acetylcysteine, and I'm happy to look at your answers. So any questions or comments, thank you very much for listening. You can email me, the narrator of this talk, at james.piper@ucl.ac.uk, and the Royal Free Teaching Fellows at gmail.com. Also see the acute medicine section on Moodle. Thank you very much for listening. Your next case is coming up.